Hello and welcome to the Coronary Corner by SYSTOLE. This is a podcast with my colleague, Dr. Yader Sandoval. And in this second episode, we're going to discuss a little bit more about CT-guided PCI, specifically talking about the how-to. So Yader, in the first one, we had a very detailed conversation about why it is important to learn how to do CT-guided PCI and understand the CT angiogram. But that's the first step. And then, of course, what comes next is to understand how to actually do it. And obviously, there's a lot of things and hands-on we need to do, but maybe we can explain to people some of the key principles and the key things they need to learn so they can provide maybe not expert, but good enough understanding and interpretation of the CT.
Absolutely. I think it's a great topic. I think over the past few months, recent years, there's been a lot of interest on CT-guided PCI as we were discussing in the last episode. But and of course there's all these beautiful images that you see. This 3D volumes or calcium or physiology based from CT. But ultimately, rubber hits the road, and then you have to do it. How to like anything in life, right? You can see a beautiful CT or PCI, but then you have to figure out how to actually perform.
And again, maybe you don't need, as you say, you don't need everything. You need to know the basics so you can operate the car, and then you learn more as you go by.
Correct. So I think you have to understand, is there value in this? And if you believe there's value and promise, then what are the steps to get this going? From my perspective, and you tell me what you think, I think before we talk about the specific steps, I would say that a beautiful thing about this emergent field of CT-guided PCI is that it's really multidisciplinary. So we are in the cath lab. We are taking care of patients often, at the end of the spectrum, in which often many of those, they already had a CT that demonstrated that they have coronary artery disease. But these CTs, how is the CT performed, which scanner, what protocol, did they use beta blockers, did they use nitrates? All these things are done by our colleagues, our cardiac imagers. In some hospitals, they may be cardiologists that have advanced cardiac imaging training. At other hospitals, maybe radiologists or a mix of those. But inevitably, if you say how I heard this great talk by so-and-so or this emerging thing about CT-guided PCI, I would say that unless you have that already, you want to reach out to your cardiac imager and say, can you show me what software do we have available? What is our CT reading software? What are the elements? How do I open it? And the number one barrier, I would say, people don't even have access to the account to open the CT reading software. But you
yeah, absolutely. And it's funny you say that, because I remember when I first got to Minneapolis Heart, which was back in 2016, the very first patient I did was a patient from John Lesser who had a CTO and had a coronary CT. So I was looking at the CT and had no idea what we're talking about, but thanks to John Lesser, and for people who don't know, John Lesser is a former president of SCCT. He's actually an interventionalist who trained in imaging and then became an imager. So he has an amazing perspective because he's not only an expert in doing interventions, but also the imaging part, and can marry the two. So I was extremely lucky to have one of the most gifted teachers. But essentially, walking through the pathway with him was so much more fun and makes so much more sense. And since then, I have had countless cases where I wasn't sure what to do. It was very complex, and sitting down with him really helped me make a plan, understand the anatomy so much better. And even now that I can see the CT a little better than I did before, still there's so much value to be added. So you cannot overemphasize the importance of working together with your imager, because everyone wins in the end. And they understand some things better than we do. We understand some other things that they don't deal with on a daily basis, but the synergy is wonderful, and also it's more fun. It's great to talk to other people versus just being locked in the cath lab all day.
No, and it's an excellent point, and we can go back to an observation that you made on our last episode about how we can learn from the lessons from structural interventions, right? For those they're listening to us that don't only do coronary interventions, but our structural interventions, this will resonate a lot, right? Because these people have been, they usually go to a weekly conference in some room often, and they're looking at this stuff for their valve planning and not. So it is. We are bringing now this to the coronary world, that partnership and collaboration. I find it very valuable, not only because we learn from each other, right? We learn from them about all the opportunities with imaging and how to best do these interpretations and assessments. They learn from us in what is the information that we need in order to perform the procedure. So there's really a great communication, a back and forth about what those needs are. But something that I find incredibly important is that sometimes again there can be a lot of excitement and thrill to like, oh, let's do this new emerging technology, but there are caveats, and inevitably the cardiac imagers, the radiologists that know the intrinsic detail, the small details about the image quality or artifacts or that's not the best application for that, will keep you honest about some of the potential caveats that are also very important. So really underscore why, yes, we as interventionalists need to get comfortable with CT for CT-guided PCI, but why I would say the number one element in the how is you want to reach out to your cardiac imager.
And also, I think their interpretations and their reading of the CTs changes over time. So now, for example, for CTOs, which will make a full podcast on because it's a more complex topic, but just on the surface, now they give us the angle that is best to visualize the occlusion. They give us the length. They give us the quality of distal vessels. So essentially, they are mirroring the way that we are reading the coronary angiogram. And this didn't happen overnight, but it was been through the collaboration over many years, and for them seeing what we want and for us to see what they can provide, that creates these myriads and provides the good synergy and the good outcomes. But the other thing that fascinates me with the coronary CT is, as you said, that there is always something new. For example, there is an artifact. There's this patient, as you may remember, in the second CT-guided PCI course, patient arrives to the cath lab, and guess what? The severe 90% lesion is gone. So a miracle happened. Actually, no, it was an artifact that wasn't picked up. So all these things might be too much for an interventionalist who doesn't read CTs every day to do, but for the imager, it makes much more sense. And learning together, I guess you get better and better at interpreting those. But maybe if we go back to the specifics. So what is the first step? For someone, let's say, is an interventionalist, and let's say I have been practicing for 10 years or 15 years, and I'm not trained in CT, right? I have no idea. And I want to learn it. So what is the first thing I should do?
All right. So besides, as I said, number one.
After talking to the imager.
Talk to the imager.
So talk to the imager, and then what next?
Find out the software and find out the password, username and password. This sounds like simple things, but it is a very. So okay. So you're past that initial step. You have
actually, let's talk about this because I remember it took me several months to get to that step. So I think what you said is very wise, but this is probably where 90% of people stop and don't come back. Is you're trying to look at the CT, you're trying to log into whatever is your local system for looking at CTs, and you cannot get in. And I think what happens in many places, including ours, is that you have to get special permission. It's not like the coronary angiogram, but anyone can open anything. But instead, this is actually a specific software that there's license for, and you have to get a password to get into the system. So don't underestimate that step, because there's nothing more frustrating when you want to look at the CT and you just cannot get in the system.
It is a critical step, and us interventionalists at an internal level at the hospital, but also at a societal level, at different levels, we need to advocate why we need this access, right? Because the access is usually provided to people that are reading this officially and billing for it and whatnot. So therefore, we're not in the pool of like, oh, you get a license, Dr. Brilakis, to read this, because you're not like reading this as a day-to-day as part of your job. So therefore, you have to make the excuse. But again, for all the reasons that we've discussed in the previous episodes, this is increasingly being important for how we care of patients. So yes, you have access. You are able to look at this. Ideally, you should be able to have access to this, to look at this everywhere, right? You want to be able to ideally look at this. For example, myself, I have access to reading the CT in my office. I can read this in clinic. I can read this in all of our cath labs. So access to image is key. Now, you have access.
But if I can say, actually, because I think you're on the one extreme, because I think you're the only person I know that as an interventionalist, you have the CT images at home. You have them in your phone based on the FFR CT. You have them in there. So, for most people, okay, you don't have to have it at home. Just for the audience, having it in the office is okay. But what you need is a username and password, so you don't have the frustration of being locked out of the system, so you can pull up the images that you want to see. But now, once you get to that first step, then obviously if you have an image, they can look together. But let's say you want to be able to, independently get a sense of what we're talking about. So what is the first step you should do?
So, as we'll discuss during this episode and others, there's all the softwares out there that can be used to support CT-guided PCI. But as a CT-guided PCI 101 and for pre-procedural planning, any CT reading software will give you some basic elements that we have, to be honest, us in our field, we have ignored, I would argue, for a long time, that are there, and they're free information, all right? So maybe we can start with a couple of those. I don't know that there's a particular sequence. I will just make that point, and some people might feel particularly strong that this is the number one step or that one, but you know, why don't we start that you just can just go to an axial view, scroll through the axial view, and see where the coronaries, where the origin of the coronaries are. I like actually how our friend Carlos in Belgium teaches this in a very practical way. He will say that the RCA needs to come around 11 o'clock. If you think about that, aorta as a circle, and the RCA comes around 11, and how the left coronary system should come around like 3 p.m. or so. So if you think about that sort of like as a clock, you know where this artery should come when you're scrolling an axial. And if they're not coming at those origins, then let's say the RCA it's not coming at 11, but it's coming more right in the middle, that's maybe an anterior takeoff. And maybe rather than using a JR guide, you need an AL1 guide. So again, this is such practical information. You just literally scroll through an axial. But I would say it takes you one case of an anterior right that you've gone through 7 catheters, and you saw from the CT pass me the AL1 up front to be convinced that there's value. You tell me. We've had all these cases that sometimes you have a collection of catheters trying to engage an anomalous or arterial vessel, right?
No, absolutely. And I think the coronary anomalies, this is the patients who are okay, but even the not very common, but coronary anomalies, you have, let's say, anomalous right coming from the left or vice versa, anomalous circ. If you come to the lab and you don't know this, you're going to spend, for sure, a lot of time, some extra contrast, and you may not even get an answer. So just knowing that there are 2 coronaries and they're coming from where they're expected to come, that's very important. And sometimes you can look at this even without having access to the specialized software.
Correct.
Most packs will just show you the actual images as you gauge. So even if you don't have that software, just by scrolling down those images and seeing that, yes, I have the right coronary coming from the right cusp, the left coming from the left cusp, you already know much more than you would otherwise have known going into the cath lab. And by doing that, you can select your guide catheter, but also you're not going to have a weird case. The other day, we were doing a right heart cath, couldn't get the wire down. And it took us like 20, 30 minutes. Finally, we realized this was actually a left-sided SVC. And the funny thing about it is the patient had a CT. But I had not looked at the CT. And then now that I went afterwards, of course, there it is.
Yeah.
But so that's again to the point that it's not just, and it wasn't in the report. So it was not in the report left-sided SVC. So that's why you need to know how to read your CT yourself, because you look at it, you say, ooh, that was the left-sided SVC. It would have saved me, 20 minutes of fluoro and going around trying to get it done. So I like this, this strategy that you just look at the axial, see where the coronaries are coming from as a first step, and choose your catheters accordingly.
And of course, a lot of this, the data right now, it's being published. There was, there's been some articles that have emerging data supporting this. But conceptually, if you know where things are, then there are fewer catheters. Hopefully procedural time, radiation contrast is lower. So that's the benefit. You're moving in a more efficient manner and using your resources more effectively. Now, what would be the next step? How would be the other practical step that all of these softwares can use, which, again, I would say it's something that we've ignored. I don't recall getting a lot of education on this, back when I was learning cardiac CT, is that pretty much all this, CT reading softwares have, this volume render images, these 3D reconstructions. It doesn't require anything too advanced. As long as you have a good quality CT, you go and click on one of these volume rendered images. The one that is increasingly being popular is this one called MIP, or maximum intensity projection. And you just do this click, and you're going to get 3 coronaries. And it's been arguably not much attention has been paid to this image because it doesn't provide the specific detail for you to say, Is there a severe obstructive coronary lesion or not? So therefore, for diagnostic purposes, it's not what many of our radiologists or cardiac imagers have used. But for us in the cath lab, this 3D reconstruction easily shows anatomy, course of the vessel. Often all the softwares give you angles of when you rotate the 3D model of what are the optimal angles that you can see the course of the vessel. And critically, they also show you whether there's calcium or not. So these are images that are very powerful because if one just image, you click and you get all this information about vessel course, tortuosity, calcium, and that's very valuable. I know you've used the MIP. What do you think about the MIP? Is that important?
So it's interesting. When I started learning this, I would ask the imagers sometimes, like, why don't we use the MIP? And they said, oh, no. They always went to the axials. And I was asking them why. They says, well, you're less likely to see artifacts. And I think it's true that if you go to the MIP alone, you run the risk of overestimating, underestimating lesions. You can not make sure you understand the anatomy as well. So from a purist perspective, the MIP is not as accurate as looking at the axial projections. But I think for us that actually we want to develop a 3D understanding of the course of the coronary artery and where the lesions are, for example, in relationship with branches. I mean, this is the best projection. Actually, if you ask me, if there's one projection I would want, that's the one. Now, I get it. You have to be careful not to use it as the gold standard for determining if it's severe or not. But still, this is a great view. And for me also, what it's very useful in that view is the calcium, because you can really see the calcium in three-dimensional format, and sometimes it's just a glance. When you see the whole coronary tree is white and dense, that this is going to be a interesting case, going to spend a lot of time. So as we're discussing in the previous podcast, you can make your plans and be able to do this in a better way. So I completely agree. The MIP sometimes comes right away. Sometimes you have to press a few buttons to look at it, but it is a very useful visualization, essentially, of the coronary tree. But I think to use it for planning to stent, the MLD, which we discussed before, you need to go to the MPRs. So you want to talk about the MPRs and how you use them for planning the PCI, need for modification, size of stent, stent diameter, etc.
Absolutely. So, MPR, are the multiplanar reformations, and the easiest way to explain this, I find, particularly for our interventional colleagues, and us that have been trying to use this, is that you could go into CT and be lost about where to click, but we know what we want because we have so many years and so many data of what we want from intravascular imaging. And again, we keep thinking about this. We want to understand vessel, the lesion morphology, the lesion length, vessel diameters. So now, if you go to these multiplanar reformations on CT and you have a good quality T with good reconstructions, good identification of where the vessel is tracking.
And to your point, if you can say, I think for most, if you have a good quality, actually this is automated. You
Correct.
click the MPR button and you get the reconstruction. And yes, sometimes you may have to submit, but most of the time you don't need to. So I think people are afraid, oh my God, how do I make the central lines, etc. But the reality is, for most cases, I think your experience may be the same, that actually you don't need to do much. It's over there ready for you.
Correct. There's different, of course, types of cases, but yes, in most cases, there's increasingly novel softwares that will give you that multiplanar information already selected from the best data set. So this technology is rapidly being provided in an easier way. But now if you go to this multiplanar informations, think about OCT or IVUS, that you do the pullback, and if you remember with intravascular imaging modalities, you usually get at the bottom with many of the softwares, you get the pullback of how this looks on intravascular imaging. It's pretty much the same thing with CT, in which you're going to get a display longitudinally of the vessel, and therefore you can scroll through the longitudinal vessel and get a cross-section at each segment. So therefore, what we've adopted from the intravascular imaging that they've used, for example, the MLD, is that you can do a CT-based MLD, right? And you can use this multiplanar reformation to understand where is the lesion. Once you understand where is the lesion, you can pretty much scroll and understand where is the proximal and distal healthy reference segments. Once you understand that, you understand, of course, your lesion length. But beyond lesion length, if you understand your landing zones, you know, well, I need, here's healthy to healthy, I need a 20 millimeter stent. So you know where the lesion is, how long your stent is. And a critical thing of this multiplanar reformation is that, of course, you can zoom in on a cross-section. And this cross-section is like any cross-section from intravascular imaging that, of course, you can just scroll down and understand, alrighty, is there calcium or not? This is something that we should discuss at more depth in, in some of the future episodes. But this whole discussion of calcium is that practically you're trying to say, is this a complex, a calcific or a non-calcific lesion? And if it's non-calcific and you say it's focal, you say, I need a regular balloon, I need a 20, and I need a 20 millimeter stent, and you're done. The final component of this, of the cross sections of the multiplanar reformations, is vessel diameter. And a critical point to discuss before we wrap up this episode is this issue that yes, we can get some hint of the information for vessel diameter, but it's incredibly important, and this goes back to this issue of how in the multidisciplinary collaboration that these CTs are acquired with proper vasodilatation and nitroglycerin. We think it's we take it for granted because, for example, all of our CTs are done with nitroglycerin, but that's not the case everywhere.
And people give more, like they give 800 mics, so 2 sublingual nitro, so much more than we do in the cath lab or in the patient. So it's important, as you say, to make sure before you measure that it is done in the proper way, because if not, then you risk underestimating and putting undersized stents, which can be a problem.
Yeah. So again, I would say that the understanding vessel size is probably something that we need a little bit more experience, but if it's properly dilated, I would say at least you know where to start sizing. So, and something with CT is that sometimes it's slightly undersized compared to, like, let's say an EL base modality. So let's say the CT says the lumen distally is 2.3, you can probably go with at least upsize half a balloon and dilate. But again, for this particular episode, talking about the 101 of the how of CT, as we've discussed, you can do, you can understand the axials for vessel origin. You can do the MIPS to understand case complexity and anatomy of vessel course. And then you can do the CT vase MLD, which is largely a lot of this multiplanar reformations to understand length, morphology, calcium, and get less ahead of vessel diameters.
So to summarize, for the audience, what you have to do is, number 1, talk to your imager. Number 2, get the password so you can get on the machine and the software and get the answer. And number 3, look at 3 things: the axial view to look at the coronary origin. Number 2, the MIP. Number 3, the MPR. And on this point, thank you so much for being with us today, and look forward to having you on the next podcast.